I'd like to welcome this evening Professor Alex Richter, who is a clinical immunologist based at Birmingham University and Queen Elizabeth Hospital. And Alex is a clinical immunologist, so she's going to talk to us again on something extremely topical, which is the immune response or the immunology of COVID. So I'll hand over to you, Alex. If you take the screen, it's all yours.
Thank you very much, Will. It's an absolute pleasure to be invited to talk on this wonderful seminar series. So I've been given the grand challenge of running through the immunology of COVID in 15 minutes. So we'll have a very broad overview of the subject. So I guess the first thing to think about is what is the threat? And this is the SARS-CoV-2 virus. And we need to know a little bit about the virus because actually it is the proteins of this virus that the immune system is recognizing. So you've got the spike protein, which is the protein that interacts with the ACE2 receptor on the host and enables viral entry. And actually on the spike protein, it's the residual binding domain, or the RBD, that facilitates this viral entry. And then we've also got the nucleocapsid protein. There are other proteins, of course. There's membrane proteins, envelope proteins, but actually these are the key proteins that have been used in a number of the tests that we have developed and are probably in relatively common parlance. So thinking about COVID and infection, the more I'm thinking about the immunology of it in my head, I'm thinking about the initial viral infection. And actually, we don't know a lot about this because we haven't really investigated people who've had a mild illness. And we're assuming that the viral infection is very similar to other coronaviruses. So type 1 interferons triggering the innate and then the adaptive immune response. And this is probably quite important because your initial viral infection accounts for about 80% of all disease. We also have asymptomatic infection, and of course understanding the immunology of that is even more difficult. But then as you develop a viral infection, at days kind of 5 to 7 to 10, we see to get a more established immune response. And this is when we are looking at the pneumonias and the hyperinflammatory ARDS, cytokine storm scenarios when our patients are on ITU. And I'm thinking of this as quite a late phase of the viral infection and actually starting to overlap with more of an immune-mediated disease. This is particularly pertinent with the PIMS-TS children, where we've found that children can be PCR negative, but be antibody positive. And not just antibody positive, their memory antibody, their late memory antibody, IgG, is positive, but their early antibody, IgM, might be negative. So it does seem like in PIMS-TS, and I think that we've also seen a very similar hyperinflammatory syndrome in adults, that you have this very delayed immune-mediated disease. So thinking about the pneumonia and the ARDS, the cytokine storm, the macrophage activation, we probably all recognize a high neutrophil count now and a low lymphocyte count and the ratio that creates. And we know quite a lot about this part of the disease because it's been studied really well. The ISRIC study has been a huge collaborative effort across the UK. And we are really starting to characterize some of our sickest patients with COVID in detail. And this understanding is so essential, potentially moving into a second wave or, a period of prolonged illness with COVID over the many next years. So, we've found certain things, like we know that the sicker patients tend to be older. They may well have hypertension. They may well have diabetes. There's also a potential ethnic relationship. So understanding the relationship between the virus and the host is very important. And this spectrum of disease tells me that actually there are very distinct differences with an individual's immune system and how that immune system is reacting which is why we're getting the spectrum from asymptomatic to really quite severe cytokine storm disease and death. So with this more severe hyperinflammatory end, what we're getting is an over-exaggerated innate immune response. And the innate immune system is made up of the cells of the innate immune system, so neutrophils are very important, but actually a number of cytokines, inflammatory cytokines, like such as TNF, IL-6, IL-1, and others are important. Why these cytokines have been individually measured, and it's useful to know their results because actually they're informing potential drug trials and drug studies. And certainly we'd have heard of, infliximab, adalimumab as anti-TNFs, haven't been specifically used in a full study yet, but tocilizumab, an IL-6 receptor antagonist, has been used. But the one anti-inflammatory signal that we've had that has worked to date is from the recovery trial, and we found that dexamethasone, which suppresses all these innate inflammatory responses, has been successful in hospitalized patients with significant disease. So it tells us that we can dampen down that innate response and stop it progressing. And in response to that, things like the CRP and the neutrophil lymphocyte ratio change. So the innate immune response is a very hyperimmune inflammatory response, but actually that's not the whole story, and part of clearing an infection requires the adaptive immune system to kick in. Of the adaptive immune system, you've got your T cells orchestrating this, and you also have your B cells, which of course are important for antibody. Now, if we start with the T cell response, certainly we've seen that lymphopenia or low white cell counts has been associated with COVID pneumonia and ARDS and a bad prognosis. So people have done a number of studies trying to characterize these T cells to see if there is a clear biomarker of severity, but none has been found to date. But what we do see is a profile. So we see a profile of reduced regulatory T cells, of reduced memory T cells, and increased naive T cells, which can be primed to produce an inflammatory response. Similarly, increased and activated cytotoxic T cells, which are very important in viral immunity, along with NK cells. So it's much more difficult to measure cells and do cellular assays as part of large research studies. And so there's a little bit of a backlog, I think, getting collected data, for example, from ISRIC or from other big collaborative studies. But there are some research projects coming through, and we certainly know that T-cell immunity is an important element of protection in COVID. And the T-cell assays that are being developed are now being brought into clinical use, not just in the acute setting, but thinking about the convalescent setting. So what does the T-cell and the adaptive immune system look like when the patient has recovered? So similar to TB, where the T-cell response is so important, when we look to see whether someone has suffered from TB when they recover, we do an ELISpot test, and we look to see whether challenging a patient's T-cells can, with TB, or in this case with COVID, can generate interferon gamma as an inflammatory cytokine. And these assays are being developed and are improving our understanding, not just of the acute phase of the T-cell response, but the convalescent phase and the memory phase of the T-cell response. So the other arm of the adaptive immune system is, of course, antibodies. And I'm sure you will recognize this picture from medical school. You have an infection, and then your early antibodies, your IgM antibodies, come up very quickly. These are less specific, but they are produced in larger quantity. They haven't gone through a lymph node, so they haven't been class switched or gone through a regenerative process to try and become a higher affinity antibody, such as the IgG and the IgA antibodies that are produced later. So IgG and IgA antibodies are a much higher affinity antibody, and they come up maybe 7 to 10 days after an infection, and these then persist, and it is these antibodies that are part of the memory response as well. So we measure these in a number of viral diseases like measles or mumps or rubella, and we will test many, many years after vaccination or infection to see whether these antibodies are present, to see whether a mother, for example, is at risk during her maternal workup. So we are looking at doing testing for COVID-19 to try and understand whether an individual has been infected. And the way we're doing that is with mostly IgG antibodies, because G antibodies are the most prevalent in the blood. Some assays are using IgA as well. And some assays include IgM to try and get that early response. Now, what we've found in a number of studies is that actually the antibody response in everyone is not the same. And why would it be? We certainly find much higher antibody levels in patients who have been particularly unwell, and antibody levels are much lower in those that have been asymptomatic. And the other thing that we've found is that antibodies are higher in those of an older age. So there are differences, not enough that we potentially need normal ranges for different ages, but it is just worth knowing. Most tests are set up to be qualitative, so they give you a yes-no answer. But as the research and the understanding of the immune response to immunology is so important, having some quantitation of these assays is very helpful. So why would we use an antibody test? Well, it might be for an individual to support diagnosis in a hospital or community setting where there is a really high clinical suspicion, but the PCR is negative. And actually, we know the PCRs are probably only positive in about 80 to 85% of cases. And certainly we've used antibodies when our children came with the initial PIMS-TS outbreak, and our initial cohort was all PCR negative, but we were able to pick up that they were all strongly positive on antibody. The second reason we might do antibodies is to determine exposure when a PCR test hasn't been undertaken, so prior to widespread PCR testing, or if there has been asymptomatic conversion. We also might want to know whether an immune response has been generated following COVID-19 infection or vaccination. Certainly, I see a lot of patients with immune deficiency, and with very many vaccines, they don't produce an immune response, and they may not produce an immune response following natural infection. So actually understanding someone's risk of reinfection might be possible with the use of antibody testing going forward. We can also use antibody testing in a research in a public health setting, understanding the longevity of the immune response in patients previously confirmed with COVID. This is important for knowing how long immunity is going to last for, and also thinking about the future of vaccines. Is one single vaccine course going to be enough? But if immunity wanes from that vaccine, are we going to be having our annual COVID injections along with our annual flu injections? I think antibody testing is essential for seroprevalence studies for research in public health. Certainly one study that we did at Queen Elizabeth Hospital looking at healthcare workers had surprising results, that we found that actually the cleaners and the acute medics had very high antibody conversion rates, much more so than the intensive care patients, where you might have thought that they would have a higher risk of contracting the virus from their patients. We need, however, to determine what is a protective antibody level. And the only way we're probably going to do this is with neutralization assays. And this is where you can either use pseudoparticles or you can use live virus. And you add an antibody system to them to see what level of antibody can control or kill that virus. These are underway, and I'm very much hoping within the next few months, and certainly before the winter starts, we will have a much better idea of what a protective antibody level is. And then, of course, there's a great talk next week on vaccination. We're all desperate for a vaccination, but actually to determine response to vaccination, we often use antibodies as a surrogate of protection. Big epidemiological studies are required to see whether they are effective, but when the incidence of a disease is low, one way of looking for protection is with surrogate antibody levels. So what does my antibody test mean? If it's positive, you've had prior exposure to the virus and you've produced an immune response. The caveat on that is that sometimes, in a very small percentage, you can get false positives. And we think that's probably to do with cross-reactivity with either other coronaviruses, and there was a report on dengue fever this week, but there will be a few cases. A negative test, no prior exposure to the virus, so they haven't seen COVID or had it, or they haven't had an immune response to the virus, or that response has waned. So some clinical interpretation, I think, with the test, as with all the tests we do with pathologists, is very helpful for enhancing the quality of our tests and their performance. Because, of course, the test may not be sensitive enough. We do know that different viral proteins can affect the sensitivity and the specificity of the test. We know that the nucleocapsid comes up very early, so it's very good for detecting antibodies early in disease, but it may not persist at higher detectable levels following mild disease. You know, which antibodies we use may affect the sensitivity of the test. So one study we did looking at total antibody levels and then looking at individual antibody levels found that so about 3.4% in this study were IgA positive alone and with no IgG or IgM. And that just suggests to me that having IgA may just bring a little more sensitivity to the test. And the other thing to think about is the performance of your test and the pre-test probability. If there's a low incidence of disease at that time, so at the moment, the chance of being correctly positive on a test can sometimes then be lower than the chance of a false positive. So if we're going to be using antibody tests for screening, we really do need to know not just the sensitivity of the testing for modeling, but what the pre-test probability is. So that's a very, very quick 15-minute, slightly over run through on immunology, and I'd be more than happy to take any questions.
Okay, thanks very much indeed for that excellent overview covering innate and Tcell and Bcell responses. So I have a few questions, but please feel free to carry on asking questions. On almost your first slide, you showed a list of factors associated with increased mortality. And whilst age was a very obvious one, there were a number of other pre-morbid conditions. But strikingly absent from that list was immunodeficiency. Now, is that because the pathology is immune-mediated and immunodeficient patients don't get severely ill, or is it because they've been so effectively shielded that they haven't been getting infected?
Well, one, they're a fairly small population, so compared to the larger population, it's going to be a small signal. Right at the beginning, with the UK Primary Immunodeficiency Network, I set up a registry. So we have been monitoring our patients, and we have got over 100 patients now on the registry. And actually, their case fatality rate is higher than the background population. Obviously, it's skewed that we have only those that have been reported to us, and we will get that data out to the community as soon as possible. So I don't think it's true that their immune system has been suppressed. What we're starting to worry about now is that actually we've got a number of immune deficient patients who aren't clearing the virus and are persistently not just PCR positive, but PCR unwell positive. I've got a lady who has no B cells because of rituximab and secondary immune deficiency, who's on she just finished her second course of remdesivir and has just unfortunately started spiking fevers again. So we are going to have to think about this cohort because they have been protected and they did shut down early, they have isolated, and as they come back out into the community, I think, we are going to have to think of ways from a patient point of view of managing them, but also from a public health point of view if they're not clearing the virus.
Okay. You moved on through innate immunity to T-cell responses, and you mentioned T-cell responses are much more difficult to measure as a routine. In the ELISpot assays, can I ask what is used to stimulate those cells? Do you use whole virus or just individual proteins or what?
So this would be individual proteins. So people have tried, have used very similar to the antibodies actually. So they've used spike, they've used RBD, and they've used nuclear capsid. And actually all the T cells, convalescent T cells, can respond pretty well to all three of those targets. One paper came out recently suggesting actually we may have some cross-reactive T cell immunity. And they found that actually some T cells recognize other coronaviruses. So it may be part of the explanation for the spectrum of disease is that actually we do have some T cell cross-reactivity, but there's only been one paper out on that, so we'd like to certainly know some more. Okay,
but it raises an interesting question, which is, would measuring T cells be a better marker of seroprevalence? It's not the right word because it wouldn't be seroprevalence. But would measuring T-cell responses be a better way of assessing the degree to which the population has been exposed to the virus rather than measuring antibodies?
I think we don't know that. I would argue that the antibody tests they're easier to validate and there is less variability with a protein antibody test than there is, for example, with a functional T-cell test. There is, a much larger CV with those tests. Also, it's logistics. Obviously for antibodies, you need serum, and we've proven that our assay works as well on dried blood spots as it does on blood. Whereas for a functional assay, you've got to separate out the cells. You've got to potentially, you've then got to stimulate. You've got to make sure that it works. And actually, the logistics of screening by T cells, certainly at population-based level, is very, very difficult. I'm hoping that when the vaccine studies come out, because these patients have been looked at in so much detail, that actually we will start to understand better the balance of the T-cell and the B-cell responses.
Okay, so if we move on to the B-cell responses, we actually got this question last week, and I did say I'd bring it back to the immunologist this week. Have you seen a paraprotein in any of your patients?
In any of the COVID patients?
Yeah.
Oh, no, not on the COVID antibodies, but we have looked on lateral flows and seen how a paraprotein behaves on a COVID assay. And actually, the protein, it doesn't stick to the COVID, to the COVID antigen. So that was very reassuring. But it did cause a bit of a mess on the filter paper of a lateral flow. But actually, so we've not found that paraproteins interfere with COVID antibody testing.
Okay. But there's no evidence that COVID infection can induce paraprotein production.
Sorry, I didn't quite catch that.
no evidence that COVID infection can induce paraprotein production.
No, we've not seen that at all. And actually, I did electrophoresis on about 30 ITU patients, and I couldn't detect any. That's a fairly valid question, because in severe disease, you often throw off very small paraproteins, but we didn't see anything of note on this.
Okay. Someone works in maternity and has asked about the presence of neonatal antibodies. I mean, I would make the assumption that if the mother has antibodies, they'll cross the placenta, but is there any data on what protection that offers the neonate?
No, we don't know. We're assuming, because IgG antibodies are produced, that if you get COVID in pregnancy, that they will cross the placenta, and obviously then protect the mother for, the child for 3 to 4 months. We have seen COVID in a 6-week-old baby, but we're assuming that the mother contracted the COVID, and actually the story is that she contracted her illness after giving birth, so none of those antibodies would have gone through to the baby.
Was the baby symptomatic?
The baby got PIMS TS, actually.
Yeah. Oh dear, right. What about, we've found a small number of patients who we've had in hospital with absolutely no doubt they've been PCR positive, but we cannot find any trace of antibody production. Is that something you've seen?
They're few and far between. Some of it is down to the sensitivity of the assay, and I would certainly say it's worth trying a couple of different assays. So we have seen, for example, someone won't come up on nucleic acid, but they might come up on a spike assay. And why not? Why doesn't the immune system, it's a random process of the proteins that it recognizes and responds to, and it may just find it more immunogenic. But the other thing that I've seen in a couple of ITU patients is that they haven't come up with particularly strong antibodies or antibodies at all. And I wonder whether, when you're sick on ITU, your whole immune system is overwhelmed, and actually your lymph nodes and your ability to generate high quality antibody in that setting is going to be suppressed, and it's going to be impaired. So for me, it's actually quite surprising the high level of antibody in ITU patients. I would have thought it would be much lower. And Will, this brings into play that question of antibody-dependent enhancement. And you do wonder whether antibodies are definitely good, and whether in some cases, actually they may be part of the problem, and they may be generating part of the immune response. So really what we need is to measure antibodies before someone comes into hospital, and see if we can stratify them based on their antibody titer, but not just the antibody titer, the character of that antibody and what that antibody is recognizing. The other thing about that is with the PIMS TS patients, because certainly a number of these are PCR negative, and we found, certainly in the early cases, that the IgM was negative. So to me, that suggests that the infection was some time ago. So if it's some time ago, it is not a direct effect of the virus, and this must be immune mediated. So is there a molecular mimicry mechanism going on? Is there a mechanism whereby those antibodies are recognizing a target, for example, endothelial cells on the vascular system? We don't know that yet, but there's a huge number of projects, I think, going on worldwide trying to understand what's going on, certainly in the PIMS TS.
Yeah. So all of that immune response is building up to what is the $64,000 question, which is, can you get reinfected? And I suppose, can you get ill a second time? And what is your
I would say, of course it's possible, but it's highly unlikely. I mean, look at the epidemiological evidence. Yeah, we've had however many cases now of COVID worldwide, and we are not getting a strong signal. There is the odd case report where someone has, said that they've had it again. But I'd go back to the fact, was that PCR absolutely correct first time around? We know you can get false positives with PCR, but actually, like my immune deficient patients, they can get infections again and again and again because they're not producing an effective Bcell or Tcell memory response. So of course it's possible, but I think the epidemiological evidence at the moment is that I think it's highly unlikely at the moment. It's not a common theme.
So what you might expect from other virus infections is if someone recovers from one infection, their antibodies may be present, they may decline. There is increasing published evidence that the antibodies do decline. But they get a second infection, and the only manifestation of that is a boost in the antibody levels. So are you aware of any studies that have done longitudinal antibody responses and seen whether there's a sort of boost 3 months after they got out of hospital?
I think there are a number of studies. I've got a healthcare worker cohort that I'm looking at, and it's a 12-month study to try and answer some of these exact questions, Will. So every time they are unwell with something, we're bringing people back in to bleed them to see what has happened with their antibodies. And we're trying to look at the decline of antibodies. And you know, we just don't know. I mean, think about some viruses like measles. Post-vaccination, those measles antibodies are maintained for life, aren't they? They rarely wane. You know, in contrast, you know, other viruses, you know, mumps, for example, we do see mumps outbreaks, don't we, in the teenage years. And so those viruses wane, the antibodies wane to a point where the individual becomes vulnerable again. So I think for this virus, we don't know. I saw a paper last week from the original SARS-1 in 2003, and they demonstrated in this one individual, so it's N equals 1, neutralizing antibody at 17 years post-SARS. So, you know, absolutely, the virus might mutate, it might change, our antibodies may wane with time, but actually there's also a really good chance that we do hold on because we're designed essentially, and we invest so much energy in the adaptive immune response to get this memory. And for most infections, you do get a fairly long-lived response.
Okay, well, let's hope that's true. I've got some fairly specific questions that I might just fire at you. What incidence of, have you seen joint inflammation in COVID-infected cases, rather like a reactive arthritis due to immune complex or autoimmune phenomena? It's not
so
described.
I've not seen it in the acute setting in adults, but we've certainly had it reported in this prolonged COVID syndrome that I think starting to be reported. People are reporting kind of arthritic changes, inflammatory arthritic changes. There's certainly been dermatological complications like, you know, COVID toe and almost Raynaud's phenomenon. But we did see joint swelling and inflammation in a couple of the PIMS TS children. So yes, I mean, the autoinflammation, it's not surprising there is some inflammatory arthritis. And I would imagine that is immune complex mediated.
So a related question which you touched on is, and we often get questions about post-COVID syndrome or chronic fatigue. Is there any particular immune response associated with that?
I think we don't know yet, and that's another part of the puzzle that we need to get set up. There's a big study that's been set up to look at convalescence in health in individuals that have been hospitalized, so post-COVID, and they are doing a very in-depth evaluation of patients that have been in ITU or required oxygen for greater than 3 days, and that's a national project. But actually, that's the more severe end, and it's again, we need another research project set up to look at those that have had community disease and this very persistent fatigue that's been reported. You know, things like prolonged lack of sense of smell. I've heard out to, 3-4 months, people haven't got their smell back yet. So something is going on. but I haven't got my hands on a set of data yet to look at the immune response in these individuals. It may be difficult and it may be very subtle. I mean, if you think of post-viral fatigue and chronic fatigue syndrome, so many research projects have looked for an immune signature, haven't they, for chronic fatigue and never found one. So I think we absolutely need to look in post-COVID syndrome, but I don't know what we're going to find. And I think we need to kind of commute expectations of what we might find.
Okay. Someone has asked, you showed some IgG, IgA and IgM tests in the last slide. I'm struggling to remember what that was. Was that an in-house assay? And if yes, which part of the virus were the antibodies targeting?
So this is our in-house ELISA that we're commercializing, and it's against the spike protein. Okay. So it's a stable trimeric spike, and it's it very effectively picks up both G and A and M. And based on running the individual classes of antibody, we decided that actually the most sensitive assay for mild disease, which the test was set up for, is by combining G, A, and M on one plate. So the antibodies are all optimized to make sure they read at the right place.
So a related question, and it harks back to a very early talk that we had from Richard Tedder, was what is your view of the commercially available antibody assays that are only directed against the M protein? Richard's view was that we should be running a battery of antibody tests to understand the immune response.
I think so. The Roche and the Abbott tests at the moment are the two that I think that have been rolled out. They have been designed and set up, I think, in the early days to detect people who have been in hospital. So their application to a different population with mild disease, of course, there are going to be differences. So when they were launched, their sensitivity is in the high 90s, and that sounded really promising. But actually what I've found from my immunology colleagues nationally who've done validation on both tests is that in mild disease, actually the sensitivity is more like 80%. Yeah. So quite a lot lower. But, I'm not surprised. These were the first generation tests that came out, and they weren't optimized for that very difficult cutoff between, asymptomatic or mild disease and what is truly negative. Okay.
So I've had the message that we have to wrap up in a minute, and there's only one question I haven't yet asked you, which is, what is the time scale for the T-cell response?
So how quickly do you get a T-cell response? It's pretty rapid, so you should be able to get something within a couple of weeks of exposure, no problem. But it's when someone's been in hospital or been unwell, the T cells need to recover. So the inflammatory state, they're very activated, these T cells, obviously when you're in hospital. So it takes a little while for that to settle down. But yes, you can pick up T cell responses pretty early as well.
Okay. And I've just had another question, but I think I'll ask this one because it's relevant in a clinical context. If you test someone and they're antibody positive in a single assay, should we be confirming that reactivity in a second assay? We do that for a lot of other virus infections.
It depends what question you're asking, Will. And this comes down to the clinical. I mean, is an 80% assay good enough to do screening on? Probably not. If you want to absolutely know for certain that this patient is antibody positive because we now know what level, I'm just hypothesizing, we now know what level is protective, and so therefore this individual is going to make life or behavior changes based on that assay, then I would argue, yes, confirmation of that is important. But it all comes down to your trust in the test and the performance characteristics. If you have a very reliable test, then why do you need to double check it in this case? But because we don't yet know what these antibodies mean in terms of their protective level, actually we can't be making behavioural changes. So at the moment, these antibodies, I mean, I think we all want to know, we're all desperate to know, and that's the feeling I get from people is, you know, they're so keen to know whether they've had it, whether they haven't had it. So there is that kind of, I guess, the politics of antibody testing. It makes people feel good, but and there's a real public health need to know. But I would argue that there are actually very, very few clinical situations at the moment where having a definitive antibody test is going to change the management.
Okay, I would agree with you on that. And that's probably a good place to stop. Thank you very much again for giving us the overview and for answering that complete battery of questions. Fantastic. Thank you for all your questions, as ever. Please do join us next week for the finale to this series. And a final thank you to Alex for spending the time this evening educating us. Thanks very much and good night to everybody.